This episode of EMS One-Stop is brought to you by Lexapol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexapol.com. That's lexipol.com. Hello and welcome back to EMS One-Stop. I'm your host, Rob Lawrence, and I love episodes like this because I have probably my most regular returning guest, Dr. Alex Isakov from NITEC and Emory, of course, in Atlanta, coming back to give us an update on what's happening out there in the infectious disease world. Dr. Alex Isakov, welcome back. How you doing?
I'm great, Rob. It's always great to be with you here. I love you, your podcast, and the audience.
We love the audience too. Of course, they're the ones that really like and subscribe and make it happen. As always, I have a hit list of stuff to talk about today, and I know you have a great set of answers for me. And what we'll do, and which is what folk like about this particular edition of EMS One Stop when you're on, is we sort of literally go and check off all the things that are happening out there. Some of them, of course, may seem so far around the planet. So what's it got to do with us? But of course, as we know, in this small village of a world we live in, it doesn't take too long before they're here. So I'm just going to throw a few headings at you, and of course, give us the latest. And so first on the list, what's going on with Mpox right now?
Yeah, Mpox is still a hot topic, especially in Central Africa. I think, Rob, you and I have talked about Mpox before. There are different strains or clades.
Clades, yeah.
Right. The one that the audience might be most familiar with is the big global outbreak in 2022 of Clade 2B, the one that was really recognized as a risk through with men having sex with men and sexual transmission. I mean, really, encompassing the globe. That's still a concern, but the hottest concern now, endemic, meaning most prevalent in Central Africa, is this Clade 1B. So Clade 1B Mpox can cause severe disease. It can give you a head-to-toe rash, but it's not necessary to have a head-to-toe rash. People can get that illness and die when they're infected in Central Africa. And there are a number of, we talk about this in the Democratic Republic of Congo, but a lot of neighboring countries have had cases too. And then, as you were saying, it's just one flight away where this could be introduced into the community. And Clade 1B Mpox has been identified now in other countries around the globe, including the United States. There are 4 cases now: California, Georgia, New York, and New Hampshire, where this Clade 1B Mpox have been identified. And in other parts of the world as well, in the UK, Rob, I know that's home for you, and there have been cases identified there, and in Germany, and India, and Sweden. And so, for EMS clinicians, this is just another reminder, for identify, isolate, and inform, right? So how do you identify somebody might have an Mpox infection? One is this travel history, right? So if you have somebody coming from the DRC or Central Africa and they're presenting with an unusual rash or otherwise don't feel well, the EMS clinician should think, well, maybe this patient has Mpox, and I need to take some measures, to protect myself from exposure to that, the fluid in those vesicles, or the, heavy droplets from their nose and mouth. And then if I'm transporting that patient, alert the receiving facility, hey, I have a patient with a travel history and this rash that is raising concern about Mpox, so that they can take the appropriate measures to protect themselves as well. So remember, Rob, we've always talked about identify, isolate, and inform. So identify in this case is travel history plus, unusual rash and maybe some malaise, implementing the right infection prevention measures. So for this, it actually means an N95 respirator as opposed to just a face mask, gloves and a gown and a face shield. The most likely way to transmit the illness is really from the fluid in those vesicles. If you were to come in contact with those, get them into a broken skin, or put them in your eyes, nose, and mouth, you can get infected. They go to the extra length of providing respiratory protection, on the small or maybe theoretical chance that this could be transmitted by a suspended, droplet nuclei if you were doing an aerosol generating procedure. But you really need to protect yourself from the fluid in those vesicles. And listen, nobody wants Mpox, because if you get it, through some, medical interaction with a patient, and you get it. I mean, you're going to get good supportive care here in the United States, but you're contagious for, 3 to 4 weeks, maybe, as many as 6 weeks. So it's debilitating in its own right, just because you're contagious and put others at risk. So identify, isolate, and inform, protect yourself.
So those are the watchwords of this entire podcast, of course. Identify, isolate, and inform. Inform us, if you will. Marburg and Ebola. We mentioned them in the past. Again, they seem very far away from us here in the continental United States, but again, they're still around.
Yep, that's right. So, two ongoing outbreaks. I mean, you're right to say we've talked about Ebola virus disease and Marburg before. There are not ongoing outbreaks like every day of the year, which means that, as EMS clinicians, we should suspect somebody might have Ebola or Marburg if there's an ongoing outbreak, which there is today in Uganda and in Tanzania. Tanzania is the Marburg case. Uganda is the Ebola outbreak. And so again, if the patient has an appropriate or concerning travel history to one of these places in the last, 3 weeks, 21 days, and they have signs and symptoms, fever, malaise, vomiting, diarrhea, plus that travel history, that would be a red flag to say, oh, this patient, had they traveled to Tanzania or to Uganda, could have Ebola virus disease. So, the good news about both of those outbreaks is they're much smaller than outbreaks that have been recorded in the past. You remember the massive Ebola virus disease outbreak in 2013 through 16.
I was
With,
just thinking back to that. How many years ago was that? And of course,
yeah, a decade now.
and we probably have a lot of new folk now that have sort of come into the EMS, world.
That's right.
But
That's right.
every large service, we certainly had one. We called it jokingly the Ebola coaster. We had that ambulance that was decked out in the plastic,
Sure.
and it was standing by to stand by. And we had one really close, realistic false alarm where we, deployed the full thing because of the travel history, as
Yeah,
you
that's
mentioned
right.
before, of a particular patient.
Yeah,
It was
that's right.
all good in the end, but my
No,
goodness,
that's
we
right.
had to go through the process.
Remember, that was a massive outbreak with something like, 28,000 cases
Yeah.
and, over 10,000 deaths in West Africa. And, Rob, as we experienced here in the US and other parts of the world, when you have a massive Ebola outbreak somewhere in the world that isn't well controlled, it puts everyone at risk. It was where Identify, Isolate, and Inform was born for us in the United
Yeah.
States, is from our need to recognize somebody with that travel history. So these two cases, the Marburg outbreak in Tanzania and the Ebola outbreak in Uganda, are very small, just 9 cases, 1 death in Uganda, 10 cases of Marburg in Tanzania, and 10 deaths. Several dozen close contacts being observed. The hope is that all of those contacts will go through the incubation period without development of disease, and those outbreaks can be declared over, which would be good for all of us. But Rob, another viral hemorrhagic fever that we talk about also is Lassa fever. And Lassa fever, it's not quite, it won't make you quite as sick as Ebola and Marburg. And with Lassa fever, there's outbreaks every year in West Africa. So Nigeria, Guinea, Sierra Leone, Liberia, they have outbreaks every year. But this is a particularly bad outbreak this year. And so we also have to be, on the lookout for travelers that present with fever and malaise and maybe GI symptoms who've had traveled to West Africa. And just so that we're clear with the audience, when someone comes to us with a complaint of fever and malaise, and they've traveled to certain parts of Africa, like top of mind for us should be, well, could they have malaria? Malaria is much more prevalent, but Lassa fever is a concern if they're coming from an area like these countries I mentioned in West Africa where it's endemic. And in fact, there was a case last fall. I'm sure you read about it, where there was a traveler returned home to Iowa who developed some generalized, malaise, fatigue, and was, seen in their community hospital. And then ultimately, as they were kind of deteriorating, They escalated their care to the academic, health center in the state and determined that the patient actually had Lassa fever. And that patient, regrettably, they died. But the challenge for the EMS community was that, once public health identified, over 100 to 150 close contacts of this individual who didn't, weren't wearing the appropriate PPE because the diagnosis had not yet been made. The question for the EMS community is, well, are we ready to go pick up the next close contact that develops signs and symptoms? Are we prepared to take the appropriate infection prevention measures and safely transport this patient to somewhere where they can get assessed? And this is actually where some of the efforts of the providers in those communities to be prepared for high consequence infectious diseases through some education and training before this was even, recognized as a threat came handy, as did some of the resources of the Regional Special Pathogens Treatment Center in that HHS region out of Omaha, Nebraska, as well as the NETEC, lending some expertise and review of policies and procedures. And, I'm happy to say, two things. One, the EMS communities in these affected areas, I believe they were prepared to take the next, patient that developed signs and symptoms safely to a place where they can get evaluated. So that was great. Kudos to them for being prepared and taking the steps necessary. The other thing I think everyone was grateful for is that none of those close contacts developed Lassa fever, which was fabulous. But, like you said, Rob, we think about this as something from another part of the world. But in this case, this was a single traveler who developed Lassa fever, regrettably, died of the illness. But it didn't end there. I mean, there was, a 21-day incubation period where others that had had contact with that individual, where there was concern they could have developed signs and symptoms, and the community had to be ready. So another identify, isolate, and inform, in this case for West Africa, malaise, fatigue, fever, within 21 days of travel.
Excellent. I was going to ask the mystery Democratic Republic of Congo illness, but before I do that, you just made me think about something there around the fact, of course, you mentioned malaria, and I've spent 6 months in the jungles in Central America as a young soldier, taking all types of, medication to keep the dreaded malaria at bay. But of course, there's that one thing about travel inoculations. If you're going to a different, and this is not about the medic receiving the patient, this is about when the medic wants to go to some weird, wonderful, or exotic place on vacation.
Right.
Make sure that you look up what the inoculations are that you need before you go, because if you pick something up like malaria, then it's going to stick with you for a long while. So there's that kind of cautionary tale. Um, but mystery illness, Democratic Republic of Congo, Alex. There's another one coming, and DRC seems to be the hotbed of a lot of this stuff.
Yeah,
Or
I
is it just
mean,
me?
no, it does appear that way. Certainly, to us, and I think your listeners, you couldn't have missed, an article in the last several days. I mean, today's February 28th, but some articles in the last, 8 days about this mystery illness that's being investigated in the Democratic Republic of Congo. I mean, tragic for those that are affected there. What was reported was two children initially, became ill with a, presentation of illness that looks similar to viral hemorrhagic fever, with, some bleeding and GI complaints and fever. And they quickly succumbed to the illness. They were dead in 2 days. The state of affairs regarding, this yet to be determined cause of illness has resulted in over 50 deaths and a few hundred illnesses. And so it's an issue of great concern. And of course, the health ministry there in the DRC is working hard together with partners in the World Health Organization to identify the cause for this. And so, those of us who are in, safer parts of the world, I mean, read this with interest. And of course, with some trepidation, with some concern that, wow, if this is a rapidly progressive illness that's easy to transmit from person to person, what do we need to do to be prepared for that? But I'll caution everyone that I think we're early chapters on this particular illness, and most recently saw a WHO leader, indicate that it's perhaps that it was contaminated drinking water that could be at fault. And so I think there's more to know, but it's certainly something that we follow with interest.
And contaminated drinking water isn't something that just happens in the rest of the world. We look at some of the recent water issues here in
Yeah,
the US,
yeah,
Richmond,
that's right.
Virginia,
That's right.
most recently with issues with the water supply.
That's right.
We're going to leave the rest of the world behind for a minute and have a quick message from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
And we're back. And as always, please make sure that you like and subscribe on the platform that you get your podcast from, or indeed, if you're watching us on YouTube, make sure that you subscribe there too. And as I always say, every time an episode of EMS One-Stop drops through subscription, you get notified that we're there. I'm here with my mate, Dr. Alex Isakov from NETEC and from Emory in Atlanta. We're talking about infectious diseases. We had a quick canter around the world before we went away for the break. Now we're back home, and there's stuff going on here, Alex. And I think the last time we chatted, we were deep in the heart of H5N1. Where are we today?
Yeah, well, the H5N1, infections and the spillover into dairy herds and and bird flocks, it's continuing. Now there's
Don't get me started on the price of eggs. Sorry, carry on.
Well, yeah, you're absolutely right. So I mean that's a very tangible
Yep.
consequence. So 70 human cases now, of H5N1, influenza. Most all through contact with either, dairy cattle that are known to be infected, or poultry that are known to be infected, and some, not songbirds, but other like waterfowl and bird populations that you might come in contact with. Still no evidence of human to human transmission, which is good. Actually, critically important. But the reason that there's concern about what seems to be a very difficult virus to contain, among dairy herds, for example, is the risk of recurrent human contact with these sick animals. Whether it's occupational exposure
Yeah.
because of work with poultry or with the dairy herds, or some other waterfowl exposure. But the more human exposure there is, obviously the greater risk for human illness, but also the greater risk that this virus could potentially infect an individual who's also infected with influenza, seasonal influenza. And you get some gene swapping there, and you get a novel virus, which leads to the next pandemic. I mean, that's the concern. And so the more human interaction there is, with this virus, the greater the risk for the transformation of the virus into something that might be more adaptable to making humans sick, and maybe, allow the virus to adapt more readily for human to human transmission. And that would be, bring us back into the, dark days of managing a pandemic, which no one wants. So that's the concern. There's some other interesting elements. I mean, for, those of your listeners that are following this, I mean, there's a particular H5N1 lineage, right, that's kind of, circulating today, but there are different genotypes. So the one that mostly affects birds is one type, this D11, and the one that mostly has been found in cattle, this B313, different genotypes. Well, what's interesting is the two human cases that we have that were very sick. So there was an individual in Louisiana. He's the only American thus far that died from H5N1. He was infected with this D11, genotype. And that adolescent that was sick in Canada, who recovered, who had no other medical problems that we knew of, was also infected with D11. Now, D11 has typically been associated with the bird population, but now there's a dairy herd in Nevada where they've recovered, D11. So it's kind of an interesting sort of evolution wrinkle. The other interesting evolution and wrinkle is they've identified 3 veterinarians that have H5N1 antibodies, but have no recollection of illness, which again, then that raises questions about, well, how did, could they have been exposed, through occupational exposure? From my understanding, 2 of the 3 have some occupational exposure history, the third one not. And the fact that the virus, can exist in an asymptomatic form, right? In these cases is also a little bit concerning. What it's really raising the specter of is, are there more H5N1 human infections than we're even aware of? And it was about a month ago, I think, that CDC, issued a health alert that advised clinicians in, U.S. hospitals that if they had a patient, who was critically ill, and who they had an untypable influenza as a diagnosis, that they should send specimens to CDC for typing to see if they're infected with H5N1. The CDC just together with FDA and other federal agencies continue to do their part to try and make sure there's good surveillance for how far this virus has gone, and to try and implement protective measures to keep us healthy and safe and get the price of eggs down, Rob, like we talked about before.
Indeed, get those eggs down.
Yeah.
So I've been out to a conference already this year and I always call it the conference cold. I used to call it Eagles flu. Every time I went to Eagles, I got the flu. But seasonal flu is big and bad and out there.
Yeah, it's out there. Absolutely. I mean, at our healthcare facility, I mean, I think across the nation, public health experts have kind of who do the surveillance for this. So this is the worst seasonal flu, outbreak we've had in a decade. And influenza A is far outpacing COVID-19 this year in making people ill. And in some communities, it's putting a strain on emergency departments and hospitals. Again, it's in the past, before we ever thought about COVID-19, if you had a bad flu season, it was putting a strain on health systems. And you might remember 2 or 3 years ago, there was a twin-demic of RSV and influenza in children that was putting stress on health systems. So, I mean, this is it's always a challenge. It's for me, it's a reason for me to say get vaccinated. I know it's a hot button topic for a lot of people, but influenza vaccine is recognized as a safe vaccine, and it can prevent influenza, but maybe as important or more important, it can prevent serious illness. So, even if you contract the influenza, you'll be less sick if you'd been previously vaccinated. And that's especially important for people over 65 and, people that have other medical problems like asthma and COPD or congestive heart failure or some neuromuscular disease or something else. The other pitch I make to the EMS community is, seasonal flu, influenza is something that we can, if we're infected with it, we can shed 24 hours before we ever develop symptoms. So, that pre-symptomatic shedding. So for the benefit of the patients that we take care of, like even if we think we're immortal, and, I'm getting up with a lot of gray hair in my head. Your radio, podcast listeners can't see, but I should probably not think of myself as immortal.
Oh, we're on video. They can see. Don't worry.
I remember being in my 20s and 30s, and I was immortal. But our patients aren't. We all know that. If you're shedding, even though you don't feel, if you're shedding influenza virus, and even if you don't feel ill, I mean, some of the patients we care for, their immune systems can't, tolerate it, and they'll do worse. So that's my pitch for getting vaccinated. I'll make my pitch, for getting vaccinated against the measles too. Rob, I mean, we've seen the biggest measles outbreak in 30 years in a community in Texas, and we've seen the first death of a measles patient in a decade. in the U.S. And I mean, and this is a preventable disease, with vaccination. And the consequences of measles. I mean, report the first death in a decade, but bad viral pneumonia, encephalitis. I mean, this is not a disease without consequence, and it is it may be the most communicable disease that we know. Like, in an unvaccinated population, 9 out of 10 people or would get measles from somebody if they were exposed. Vaccination is really critically important. Most of us, have this taken care of in our childhood. It's the childhood vaccination regimen in the U.S., critically important. And for herd immunity, the audience has heard that before. You got to be upwards of 95% vaccinated in the community, or you have opportunities for measles to spread. So I know public health is doing yeoman's work in Texas to keep the community safe. And I don't know, for me, this is an opportunity to say, I mean, everyone should look at the evidence and be satisfied about a vaccine safety, but measles vaccine safe and effective. It prevents the disease. And influenza vaccine, unless you have a contraindication, is safe and effective and maybe can prevent hospitalization.
Well, thank you for saying all that. Obviously, as we all know, it's a politically trending hot topic right now. And if it's good enough for you, Alex, it's good enough for me. So thank you for saying that. I want to just come back on something. Of course, you mentioned that, flu seasons, when they're bad, are an immense strain on the EMS and the hospital system. But I don't think the general population had considered that up until when COVID came along. Because there was always these sort of numbers of, X are going to die with COVID. And of course, I go back into my stats and the various databases we have access to and go, well, actually, nearly as many would perish each winter with the winter seasonal flu as well. And so it's interesting now that that's COVID, I think, is for the general population, has raised the awareness of the fact that this is something that actually can, and as we're seeing, is deadly.
Oh yeah, I mean, certainly. I mean, and there are things that put people at greater risk for getting more seriously ill, from influenza. Again, age, pregnancy actually puts you at greater risk for severe illness. Some of those medical, conditions that we talked about, like asthma, congestive heart failure, neuromuscular disease. I mean, all good reasons to get vaccinated. And Rob, on your point. About whatever communicable disease there is that might be putting strain on a health system. One thing that came out from the COVID-19 pandemic, there was some good evidence that showed that health systems that were functioning like under surge conditions actually experienced excess mortality than would otherwise have been expected for the disease. Like upwards around 25% excess mortality, for health systems operating in surge conditions. And so, that to me, tells me, two things. One, we really got to do what we can to try and prevent surge conditions from occurring. And in my view, vaccination is a part of that equation. And the other thing too, which is really not the topic of our conversation, is, well, when the health system is operating in surge conditions, what can be done to redistribute those patients across the system, and try to avoid some of that excess mortality that you have from patients being cared for in a hospital that's in surge. And I think some of that gets to another topic, which is how medical operations coordination centers can help to redistribute patients and even the load, and let the doctors and nurses and all the clinicians in the hospitals give them the breathing room they need to take care of these patients and get good outcomes.
Indeed, and that was the whole sort of backstory to the flattening of the curve, isn't it?
Absolutely.
People would, if we flatten the curve, it helps us manage the capacity and the flow.
Yeah.
Totally and completely. So my always asked final question, Alex, is there anything I've forgotten to ask or anything you need to tell us?
No, I think, Rob, it's always, great to have the opportunity to talk with you. And like I say, you have a great program here, and you have a great audience.
Very discerning audience. They
Yeah.
love Dr. Isakov.
No, no, that's great to hear. I think any opportunity to raise awareness about identify, isolate, and inform, as a strategy to protect ourselves in the management of patients, to increase our likelihood of recognizing somebody who has a high consequence infectious disease, so we can take the steps necessary to protect ourselves and others. Any opportunity to do that, I'll take it. And then the other thing I'll provide for you, Rob, is actually, I think since we last talked, we developed a new EMS landing page on the NETEC website.
Ah, right.
And I'll provide that. Yeah, I
Yep.
mean, I think we've always had good resources on the NETEC website for the EMS community, but it wasn't always easy to find. And so, with the help of the NETEC webmaster, we've now created a landing page for the EMS resources that I hope your audience will, take advantage of, and love to hear feedback about it, and get other information up there as people think they need it.
Great. Well, thank you for that. And as always, we'll make sure that goes in the show notes. If you're watching on YouTube, there you go. There's a little image of the new landing page on the screen in front of you. And if you have any comments, please let me know here at EMS One. Alex, as always, it's a real pleasure having you on. I know you'll be back in the next quarter to give us an update. I always look forward to our chats. It's great information, and it's stuff that folk through the medium of either YouTube or indeed through Apple or wherever the podcast is, can actually listen to the latest on the various infectious diseases, both at home and abroad. So for the moment, thank you very much indeed.
Great, Rob. Always great to be here with you. Looking forward to the next quarter. Stay healthy.
There you go. You heard it all from the good doctor. Stay healthy. Of course, that was our returning guest, Dr. Alex Isakov. Always love having him on the show. So this has been a fairly short and sweet and to the point EMS One-Stop, but please make sure you take in all the points that Dr. Isakov made. So that's it for this time round, and we'll see you soon. Please make sure that you like and subscribe. All of the notes and the things we talked about are in the show notes, so have a look there and you can click through and get all the resources you need. So this has been EMS One-Stop. I've been Rob Lawrence, and until next time, bye for now.